Good morning and good evening. I am Dr. P.Y. Cho and my colleague, Dr. Junior too. We both will moderate this webinar together. Welcome to ICC today. And this is the first time at ICC after the Chang Forum 2023. Today, we are so honored to have Professor and to learn from the Professor Ravindra Bharathi. And he complete his basic medical training in Coimbatore Medical College and subsequently finished his training in General Hospital surgery in the prestigious Nutrition Medical College, Vellore in 1996. He went to unfinish his plastic surgical training in March 1999 at Madras Medical College and joined Ganga Hospital in May 1999. He is presently working as a consultant plastic surgeon in the Department of Plastic, Hand and Reconstructive Microsurgery in Ganga Hospital, Coimbatore. He has 25 publications in various national and international journals and 3 chapters in textbook to his credit. His special area of interest is in cleft and craniofacial surgery, aesthetic surgery, apart from regularly performing general plastic procedures along with hand and microsurgery. He has performed over 2,000 surgeries till date for cleft patients under the SMILE Train project, and which provided free surgeries to this patient. The topic today from Professor is my journey of cleft care in a trauma center. And we have 2 good friends invited to the panel. Professor Ike Tamada from the Tokyo Metropolitan Children's Medical Center in Japan. And the second one is Professor Boten Huang, coming from National Taiwan University Hospital. And welcome Professor Bharathi's presentation. Please, Professor.
Thank you. Thank you for those words and good introduction. At the outset, I'd like to thank Dr. Low and Dr. Tu for giving me this opportunity to share my experience and the journey of cleft care in a trauma center. So initially, I'd like to introduce our city, which is Coimbatore, which is a Tier 2 city in South India. Tier 2 is not a major city, just smaller than that. So you can see in the map that it's somewhere there. And it's popular as a manufacturing hub with a lot of textile mills and engineering industries. So now it has become a medical hub too, with a lot of hospitals, medical schools, and we are a center for medical tourism in the sense that a lot of patients from abroad to come over to our city to get their treatment and then go back. So next is an introduction about the hospital which I work in. So it was started as a small hospital in 1978, and it expanded to a 35-bed hospital in 1991. That's the time when microsurgery was introduced in this part of India when Dr. Raj Bhabati, my chief, came back. So in 1997, it expanded to 135 beds. And later it became 2000, in 2007, we moved to the new facility with a 420 beds and 17 operating rooms. So I joined in this particular period, that's between 99 and at the time, so I joined and then we moved on to the new facility. Later in 2020, it expanded further and we went in for a new block. And now right now it houses about 650 beds and 36 operating rooms. So when you talk about Ganga Hospital, it's a center for plastic, hand and microsurgery and orthopedics. So this particular one, because previously you said, even Dr. Low was surprised that Apart from cleft, I do the general plastic and microsurgery because all of us, apart from our special interests, we go on to do the general plastic and microsurgery, and we manage the emergencies. Ganga Hospital is a well-known center for trauma because Coimbatore is full of industries. We do get a lot of injuries apart from managing road traffic accidents and compound fractures. So in 1991, it was like this, and in 2020, we have a 650 beds and 36 operation theaters. So we perform about 25,000 surgeries a year. That includes both the orthopedic and the plastic surgery, because Ganga is synonymous with trauma care. So that was to our advantage and disadvantage also. So initial days when I joined in 99 to 2007, we used to see around 10 to 15 cleft related patients in a year. Because this may be due to the reputation of hospital as trauma center, because people, when they thought of Ganga Hospital, so they used to think of it as an accident and emergency hospital and not think of the other fields of plastic surgery. So we became a partner of Smile Train organization in the year 2007. Even though we wanted to have it, but only problem was till we were in the old facility, the 135 beds were always full, and we didn't have much of space for accommodating more patients. Once we moved to the new facility with 420 beds, we could accommodate these patients also. So that's when we became the Smile Train partner. So when you look into the cleft statistics, you can see initially these are on the calendar years. So around 20 operated in 2007 when we became, and gradually it started improving. But again, due to the recession, the secondary procedures were curtailed, and then there was a drop in that. Gradually, it started improving over the years slowly. And again, you can see a dip in 2020 when the COVID pandemic struck us. So that rebound caused a big high number in the 2021, and we are just doing around 120 to 150 cases per year. So what are our challenges initial days? Because when I joined the hospital, I was only the surgeons were available because cleft was not very much inside apart from the accident cases. So we did not have the team. That's the support team like the orthodontic services, speech therapy, etc. They are not there. And what we could help the patient in those, we can just do the surgery and to a certain extent just help them. So awareness of about offering of cleft services among the patients also, because again the trauma reputation was overshadowing us. So the people were not very much aware about the cleft services being offered. So slowly the situation improved, wherein because we used to have conduct the camps in various places, all the surrounding villages or the towns, smaller towns. So this is a recent shot wherein we have a big bus which carries a mammogram and diabetic screening instrument, all those things here. So previously we used to conduct in the camps, and because Ganga Hospital not only has this Smile Train for, you can see the Smile Train logo on the side. Apart from that, we do help with the Rotary Club, we do help the patients at Hope After Fire, wherein the post-burn patients are treated free of charge. Now this mammogram, with the mammogram, we screen the people for ladies for carcinoma breast, and they are also offered free treatment. And second, Walk for Life, you can see this thing that wherein the diabetic patients are also screened and free surgeries are offered to them so that the ulcer gets healed. So with these awareness camps, we are able to make sure that the knowledge about the cleft services being offered were going into the people. But now from the initial days, now we got a big team. Wherein this is a photo which was taken during Dr. Lowe's visit to our hospital. So we got a maxillofacial team wherein we can Dr. C. Kannan, Dr. Vimalambiga, Kirtana, and Nisha, all of you will recognize. She was the fellow there, and she gave a lot of inputs to me in the improving the cleft care after she returned from Taiwan. So anesthesia team, we do have the 5 anesthetists, we do have an orthodontist and a pediatrician. So, and two speech language pathologists are there, dietitian, clinical psychologist, and two social workers are there who take care of the patients in the camps. So this way we have a full-fledged team right now from the initial beginnings wherein only the surgeon was there. So we're able to offer a lot of services to our cleft patients. When you look into our protocol, so basically it's almost the same like any other this thing. We don't have anything special. We have the standard protocol which is followed worldwide. So when a child is present to us earlier enough, we always prefer to have a nasoalveolar molding at the presentation if it's possible. If the child presents earlier, we can do it. So if not, we then decide on the surgeries. At 4 to 6 months, we do go for the lip repair. At 10 to 18 months, we go for the palate repair. And 7 to 9 years, we do the alveolar bone grafting. And later, after the growth is complete, as the 18 years, we do a rhinoplasty or orthognathic surgery, whatever is essential in these patients. So we don't deviate from any of the other things. So these are the pictures of you see a unilateral cleft lip and palate with treated with nasoalveolar molding. So I always, whenever possible, I like to have the nasoalveolar molding because I just feel that the nasal shape stays much better after repair. It helps the surgeon in getting a good aesthetic outcome in these cleft lip patients. So that shows a child with this, the appliance in place and the appliance which is taken out. And that's more so whenever a bilateral cleft lip patient comes, this much more important than in the unilateral cleft lip because the uh, premaxilla tends to project out without any control and attachment and often makes our job very difficult when it comes to the lip repair. So you can see that with the nasoalveolar molding, you can see the columella which is coming up and the deviation of the premaxilla also, which is corrected with the nasoalveolar molding. This is another child which has been given the nasoalveolar molding, the appliance, and the resultant appearance before the surgery. So what were we doing when NAM was not available? In the initial days, we had to go for surgery straight away because at the time we didn't have any orthodontic support. So we used to have this thing. And of late, we have the after Nisha's return from Chang, we have attempted rapid premaxillary setback also. So this was a child which presented to us way back in 2008, just when we had started the appearance. You can see the premaxilla projecting almost straight from the nose quite far. So we didn't have much of an option at that time. So we went in for a surgery straight away. And my heart used to miss beats when I attempted it because whether I'll be able to close it properly or not, whether I'll be able to get the approximation of the muscles or at least the skin over the premaxilla. Somehow we managed to do it. We could get this sort of appearance. The lip wise went into a good union, but the problem was the vector of the pushing of the muscles, which pushed it, the premaxilla, not only posterior, it went in inferior also. So you can see that projecting premaxilla, which went down. So in this case, later, when the child was slightly older, we went in for a premaxillary setback also. So that shows the child after a premaxillary setback, wherein it's even though we know that it can cause a maxillary retrusion, but we had to do it because it was interfering with her speech also. So that gives a very good appearance after that. So that's the child after the premaxillary setback. So the child was quite confident, and then but when the growth happens, you can see that we have followed up the child. Now she's about 15 or 16 years. So now we can see that the the lip wise is still that good, but you can see that maxillary retrusion is happening and she will need further correction, which she is waiting for. So this was the tale in the older days when we didn't have the knowledge of this thing, either NAM or the knowledge of premaxillary setback. So rapid premaxillary setback, which is done during in these bilateral cleft lips, always used to be a problem because the projecting premaxilla used to hinder the closure of the lip. The patients or the child being brought later than sooner is the norm rather than exception, because most of the times the children used to be brought late by the parents. So rapid premaxillary setback involves a constant pressure on the projecting premaxilla directed posteriorly for a period of 20 minutes. So having seen that previous child, I present another child which was almost similar. You can see that the premaxilla is almost projecting like that. You can see here also with it twisted. This child was brought to us just after the COVID pandemic. Even though the parents were working in our own city, they were stuck in their native place during the COVID pandemic and could not come due to the lockdowns everywhere. So they reached around 8 or 9 months, at the age of 8 to 9 months, to our hospital. So at that time, you can see the premaxilla just going up to here. So this time Dr. Nisha was also with us, and she told about the technique being followed in the Chang hospital, where the rapid premaxillary setback was tried. So we decided to try that. You can see that this was after the anesthesia. You can see the premaxilla being after about 20 minutes of pressure. You can see that the premaxilla is also gone down, and you can see with the lip which was projecting somewhere here, it has come in level with this area. This definitely helps in the lip closure. Even though it doesn't seem that much movement has happened, you can see that still the lip is, instead of being here, there, and we got a very good result. In this case, apart from the premaxillary pressure, we just went in for a semi-open rhinoplasty. That shows the appearance of the child after the lip repair. Incidentally, it had a van der Waals syndrome with pits in the lower lip, later which was removed. You can see a very well-defined columella, the nasal shape which is being there. So this way we are able to tackle this without much of apprehension like what we had in the initial days. When we come to the lip repair, we followed the Millard's technique for the unilateral one and for the Mullican one for the bilateral one. We do a closed rhinoplasty at the same time of the lip repair, and for the skin, we use a absorbable suture with a 6-0 vicryl rapid. And at the closed rhinoplasty, we do the intracrural and ALR suspension sutures with 5-0 monocryl. So this shows one of the children which was operated. You can see the preoperative and postoperative appearance with the good lip contour and the scar almost imperceptible. And that shows the nasal shape. However well we get the nasal shape at the end of the procedure, we always found that it used to slump a bit always, even though the other things were done. So most of the people were not able to afford the nasal conformers because there are two things. One is it's not very commonly available. Even if it's available, they used to be costing a lot and the patients could not afford to change it every now and then. So we sort of devised a low cost testing after listening to some conferences, wherein we decided to do a nostril conformer using a silicone nasopharyngeal airway. It's a soft tube which is used as a nasal pharyngeal airway in the cases of palate with micrognathia. We just cut off the broad end and fold it like this. And one side of it, we cut the anterior wall, leaving the posterior side intact. So that this acts as, even though it's not exactly in the shape of a silicone nasal conformer, it could still be put inside. This shows a child which has been just operated with a good nasal shape. We just put it inside and you can see it's get retained. We teach the parents to often change it whenever it's clean and then put it on. You can see the depression of the LR suspension sutures, which are there inside here. When it comes to palate repair, we do two-flap Bardax two-flap palatoplasty for complete clefts and von Langenbeck palatoplasty with muscle repair for incomplete clefts of the palate. And Furlow's palatoplasty for the cleft of soft palate, when we are able to, it's narrower and we are able to approximate the edges properly. When you're talking about the cleft palate, we often encounter a Peary-Robin sequence also, wherein we contemplate distraction osteogenesis also in case the child is there is a failed tongue lip adhesion or the child has failure to thrive. This is one of the articles which we published in the Indian Journal of Plastic Surgery way back in 2013. This is another child. We can see a child with failure to thrive. Nutrition is very bad. You can see the retraction of the suprasternal space and here also in the intercostal space due to the obstruction. That's a severe retrusion. So in this case, we decided to go for a distraction osteogenesis. So that's the child positioned on table with a tracheostomy also we've done. So that's the child here again in the monitored in the intensive care unit. So we decided to use because the internal distractors are not available, the extraoral distractors were used for the distraction. This is the one on the left and the right and the left. After the induction of anesthesia, you can see that the submandibular incision, we put it and do a osteotomy and then fix the plate. So that's both sides we are done, and this has been brought out of the skin and the distractor is activated. We continue the distraction. That's the radiograph. We continue the distraction and we start on the same day. Within about 10 to 14 days, we just stops and can see the child, which is now comfortable and it's decannulated also, the tracheostomy, and you can see the extra distractors outside. The child went on to have a palatoplasty at a later date once it was comfortable, and that's the later at the age of around 6 to 7 years. You can see that the side profile is much better, even though the chin hasn't caught up with the growth. She's absolutely normal, and you can see that not much of scars are also the same. So far, we have done it in about 6 patients. The patients who required distraction osteogenesis due to the severe problems in failure to thrive. In ideal course, in a cleft patient, the scar should be imperceptible, the speech should be good, there should not be any maxillary growth retraction, restriction. The nasal shape should remain well corrected even without a conformer, and there should not be any need for any secondary corrective surgeries. But very often we don't get it. So I just present one sort of, usually you can see this the way you should get it. You can see the scar is imperceptible and the lip formation is quite good. So I'm presenting one such case, which if we can get it replicate in all the cases, it should be quite good. This is a child who presented to us quite way back. You can see the amount of lip involvement, and that's about a month or 2 after the initial lip repair. You can see the nasal shape holding on and the lip is missing. And that's at this 5 years, you can see still the nasal shape is holding on, and you can see the lip is very faint. Lip scar is very faint, and that's the child at the 8 years. Even now, the deviation is not all that much, and that's holding on. And we recently, now she's 16 years. I just saw her about last week. You can see that nasal shape is still holding on, although there is a mild deviation, but still the lip, everything is same. And on the worm's eye view also, you can see that the nasal shape is holding on. Because we are very difficult to predict which patient will go for how the other thing is. So the side profile also, you can see that almost there is not much of maxillary retrusion, and the nasal shape is also good. But it's very difficult to see such patients always.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70.
we're just going on an orthodontic treatment, and all others she has been quite okay, and the palate is also. But it's always not the case. We do have problems on and off with either the scar, or we do face people with coming with other problems. So this is a child which whom I operated, and you can see it's an incomplete cleft lip bilateral. And after the repair, I was really scared to find that uh, scars became so much hypertrophic. You can see that so much. So the parents were also worried, but we kept our confidence, and then we advised them for silicone gel sheet and massage. You can see that's the amount of scarring which was there. Later, as the child grew up, slowly it came down. You can also see that there's a faint marking on the nasal tip, which started growing, and this is the picture later. And now we can see that the picture is this much. This is stealing the show rather than the lip. The lip scars have faded away, and in this case, the nature has helped us very well. The scar, we just need to go for a confidently. We just go for a massage and a silicone gel sheet. Apart from that, when we whatever we operate, we do get patients from other areas wherein they get a initial treatment elsewhere with not so much aesthetic results. You can see this patient, who is waiting for surgery, had presented with a cleft palatal fistula, and you can see here also where the prolabium is quite wide, and it has not been the muscles have not been approximated properly. A few of these cases we did have options to operate. You can see this patient who came in. Again, it was operated elsewhere, so we went in and gave a correction. And this again brought the lateral vermilion to the midline, and this the immediate post-operative result. But unfortunately we could not take out the scar which is around the nasal sill. He is still on the follow-up, and I'm sure that he will do well later. And on such patient again, wherein the scar again the vermilion was been brought in to get the fullness of the lip. So this is a unilateral case similarly wherein the muscles were not approximated properly with the extra vermilion. So then when we just corrected it, and the fullness which has come back. So we did have some interesting cases also, like this was again operated elsewhere, the patient with a bilateral cleft lip. When I just see that patient here, you can see something projecting. When I intraorally saw that the premaxilla was absent, but when I just noticed it, we can see that the premaxilla is here and the tooth is coming out through one of the nostril. So we decided to operate on him. And just fortunately, we opened it up and pulled out the premaxilla, and then we just pulled it, sutured back. At the same time, completed alveolar bone grafting on one side, and later he had the other side. And that's the patient who recently we came in. So now the premaxilla is here, and the teeth are here, and the orthodontics is just getting corrected. So you can see that's the patient now. He is waiting for the orthodontic treatment, and later he will go for a rhinoplasty. So these are quite interesting cases wherein we often see that the premaxilla is positioned in ways where we don't imagine. So we did have share of older patients also. Nowadays, this is not much because these people defer their surgery not due to choice, but due to the financial problems. In that way, the Smile Train has helped us to make sure these patients have been operated free of charge. This patient was around 35 years when he came in, and he had an incomplete cleft lip, and we could correct the lip so that the patient's appearance became much better. So similar cases here again, a old lady, and they got their this. In that way. But nowadays with the awareness and the spread of this free cleft surgeries, we will not be able to see any of these older patients without surgeries presenting to us. Sometimes we do get unusual clefts with the facial cleft also. This is a child with a bilateral cleft lip with a Tessier 3 cleft on the other side also, right side. And initially we decided to do the lip repair, and the lip repair was done. At a later date, when went in to get the Z-plasty, and that was released and brought down. and this proline stent with a tube was put in for the nasolacrimal drainage. The child has grown up. Still, it requires much more correction at a later date. The right eye is not functional, and once the growth is complete, we'll try to get the those things. So we had a few other patients also with a bilateral cleft lip. Although it looks like a midline cleft, it's a bilateral cleft lip with that. You can see that the lip has been repaired nicely, but there is absence of the anterior nasal spine, and that particular area is not there. She is here, and we are planning to do a columellar reconstruction with a cartilage support and use the columellar, either in the nasolabial flap for a columellar reconstruction. So she is waiting for the surgery. I like to get the learned audience opinion or suggestions for this also. So initial days, we didn't have imaging for VPI, and this has been there with us for the past few years. We went into nasal endoscopy and video fluoroscopy. You can see the nasal endoscopy progress, wherein it is so this helps us much for going in for the vilopharyngeal VPI correction. And for the children who are not cooperative for a nasal endoscopy, we go for this also. We do have a cath lab which is used for performing angiogram in the OT. So the child is wheeled into the theater and we do this. So that gives a good definition and assessment for us pre and post operatively for the VPI correction. So once we just advance slowly from one by one with the speech therapy, all those things, vilopharyngeal inflammation. Orthognathic surgery also was being done with the facial-maxillary surgeons joining us. So this shows a girl who was operated for a unilateral cleft lip elsewhere, and she came to us. That shows the profile picture wherein we can see the severe maxillary intrusion and the lower lip projecting out. And that's after the orthognathic surgery when the facial balance has been restored. So this also again the other view, you can see the balance restored. The occlusion which was corrected by the orthodontist, you can see that normally it has come back to this thing, and that's the appearance after at the completion of treatment. The radiograph showing a good advancement of maxilla and normal relationship being maintained. So that shows the happy face of the patient with a good smile. So initially what we started as this thing was the TM expanded, we could offer services to the people in the form of speech therapy and vilopharyngeal correction, PPA correction, and orthognathic surgeries to improve the appearance of the patient. This is another patient who underwent advancement of the maxilla to correct the facial profile. Apart from that, we ventured into craniosynostosis also. You can see one child with a plagiocephaly, and that's the child after the correction. So we ventured into it, and you can see that frontal bandu and the bone being corrected with a barrel stave osteotomy being done and redripping. So with this, we are able to offer a full-fledged this thing. This shows a picture which was taken at the time of visit of the Nudov Craniofacial team, foundation team in our hospital. This is the seminar hall. You can see Dr. Lowe and the other team, and Nisha and me. That's Dr. Rasbhabati, our chief. So I would like to thank my mentors who were helpful in this my journey. Dr. H.S. Adenwala is no more. He was instrumental in teaching me the basics of the cleft training. Once we, this thing, apart from my regular training, I went to his center to visit, and he still now I follow his techniques, whatever he taught me. Dr. Sridhar was instrumental in teaching us the basics of craniofacial surgery and he helped us in the initial few cases also. Dr. Mukund Reddy also, he was helpful, and I learned a lot about the VPI correction from him. So I'd like to thank my mentors. So far the journey, how it has been. So it has been a good and fulfilling ones. So I've been able to help a lot of these unfortunate patients very well. So what started as a initially surgeon-only team, with each passing year, we were able to get more members into the team, and each of them giving their expertise on maxillofacial surgeon or the speech therapist, with each contribution from each of the members of the team. As we expanded, we are able to get better results with the patients, for the patients. So I'm thankful to our hospital and the Smile Train organization who made this possible, and our team members and the patients who placed their confidence in us. So thank you very much. I'm open for the questions or any discussions or suggestions. Thank you.
Thank you so much, Dr. Bharathi, for your amazing presentation. And also congratulations on your amazing results. So before we go to Q&A, I'd like to invite our panelists for some comments. So first, I'd like to invite Dr. Ike. Dr. Tamada, would you like to comment first?
Yeah. Can you hear me?
Yeah.
Good morning, good evening, everyone. I'm Ike from Tokyo. Professor Bharathi, thank you for your beautiful presentation. Congratulations for your results. I have 3 questions.
Yeah.
So I will ask you one by one. Firstly,
Yes.
I'd like to ask you about the insurance system for cleft care. I think your hospital is a private hospital.
True.
Are all patients treated under the support of Smile Train program?
Actually, if you see, most of the patients, almost I'll say 95% of the patients are operated under the Smile Train program. But very few patients are there who will like to get there. As of now, I'm not very sure, because much of people are getting operated on the insurance scheme. But few of the patients who are affordable, they come regularly under a private ward and they get treated and pay for it. So they are quite affordable patients. But if I say that, okay, 125 to 150 patients we operate in a year under Smile Train project, that number may be around 10 only in a year. The patients who are able to come under private and they pay for their treatment.
Okay, thank you. And second, I guess India has a vast territory, right? I think frequent hospital visits are necessary to perform NAM. So how do you deal with the burden of hospital visit for that kind of patients?
Most of the patients, within a circumference, within the city limits or just the neighboring villages, usually the patients, they're able to make their visits with their own payments. But in case we find that some people need a traveling frequently from far off places, we do provide them some amount of traveling allowance, some money we give to them so that they can come over. But when it comes to the speech therapy and other things, we can give a tele consultation so that our speech therapist go online and give therapy to the people, older children.
Are you using the online therapy?
Online therapy. So
Okay.
this is better.
That's interesting. And my last question is regarding a bit more technical aspect. In the bilateral case, short columella should be one of the difficult issues to treat. What method do you use to lengthen the nasal columella in case of bilateral cleft lip? Do you make the nostril rim incision or just the closed method like in unilateral case?
Nostril rim incision I did. If you remember the second case which I showed with a rapid premaxillary setback, we used a nostril rim incision freed the alar cartilages, pulled it up and sutured them so that the columella length was maintained. So now I try to do it in bilateral cleft lips.
Okay, thank you. Yeah, I'm confident that your future journey will be filled with success. Thank you very much.
Thank you.
Thank you so much, Dr. Tamada. And next, I'd like to invite our next panelist, Dr. Po-Cheng Huang. Dr. Huang.
Excuse me, can you hear me?
Yes.
Yeah, thank you for Professor Bharathi nice sharing about the long-term follow-up cases and some very good idea for the more detailed treatment, like to use the like the nasopharyngeal airway to do the handmat on nostril conformant is a good idea. And I have some question maybe to ask about the professor. One is the you do the rapid premaxillary setback procedure.
Yeah.
Is any detail or maybe to make to give us more some like the procedure more detail? If we must to make sure what kind of the situation, like to prevent some complication, or do you have any some peer or can give us?
So far we have done it only on 4 patients who presented. This kid was one, and all the younger patients we had, and we did not get any complications. We just kept a constant pressure, and that sort of pressed it a bit behind. So, but only one patient, slightly older child, we did that. I could get a small fracture. I had a crackling sound, but it went on to heal without much problem. So I don't think there should be any problem in this rapid premaxillary expansion. Just in between, probably you can give an intermittent pressure also instead of a constant pressure at for 20 minutes. That might reduce the blood supply. So in between, we just leave it for a minute and then again compress it.
Okay. I think you show a case about the cranial synostosis.
Yeah.
That is a very nice result. And I see you fixation about the cranial vault or cranial formed by the absorbable plate. It is very familiar and used you in the India, or it is some kind of the plate or material to do the this kind of the fixation.
We used absorbable plate, even though they cost slightly higher than the usual ones. We always make sure that we use the absorbable plates with the ultrasound welding, so it's not a problem. We always explain the patients that this is going to be costing, and we also reduce our fees so that this can be accommodated, and the absorbable plates are applied for all the craniosynostosis patients. We so far never used any wires or absorbable sutures.
So I see you showed one case to lengthening by the distractor for the medical. Also, the distraction is also used to do the sound cranial synostosis reconstruction in India.
With the distraction?
For the cranial vault distraction, or some distraction to use to correct a vector or something in the cranial synostosis.
Yeah, I think some neurosurgeons may be doing it, but we don't have any experience in distraction for craniosynostosis. Whatever we've done so far, it's an open method. We just do the open method.
Okay. Thank you for your nice sharing, and you're a good team to get a very nice result. Thank you.
Thank you. Thank you.
Thank you, Dr. Huang, for your comments. Last but not least, I'd like to invite Professor Low for some comments.
Yeah, Dr. Abi, how are you?
Yeah, fine. I'm doing well, sir. How are you?
I'm fine, good. It's good to see you again and listen to your talk. I actually visited Dr. Abi in Coimbatore, Ganga Hospital. From your description, I think everybody will know that you start the Cleft care almost from zero and gradually, step by step, and then establish a full team that not only include orthodontists but speech pathologists, but also you have
Yeah.
nutritionists, and this is very unique, and also a pediatric doctor in your team. So I was quite impressed in your hospital. I think everybody should know that Dr. Abi's hospital initially was a trauma center, orthopedic and hand surgery, plastic surgery as well. And he gradually developed the Cleft care. And I also observed his operation. It's really nice. With that, I do have some questions that I would like to hear your answer. Number one is that you mentioned that credit scar is important to make it look better or even less visible. And in your population, most of your patients may be all pigmented skin, right? So
Yes.
you expect to have more prominent scar. How do you avoid prominent scar and to have a nice looking scar? Can you answer this first?
Yes, that again, the scar forming capacity, I think formation among the patients also, even though our dark skin patients, that also differs among the patients. So if I feel at almost 90% of them or 80% of them settle very well. The few of the patients who are showing signs of a tendency to hypertrophy, I advise them silicone gel, either to apply either as a patch or as a liquid form in the night. So that also helps a lot in these patients. As I showed you the hypertrophic scar, that child was just managed with silicone gel sheet, and as the growth happened, that scar almost prominently, the prominence became less, and it almost nearly faded away. So not that all the patients go for hypertrophy. I'll say around 10 to 15% maybe. And it's very difficult to predict who are the kids who are going for hypertrophy.
Yeah, right now in our center, we very frequently use Botox to
Okay.
inject the lead muscle, even in primary as well as in secondary lead repair. I think it's quite helpful. So maybe you can consider to add Botox.
Yeah, probably I should
So,
consider that.
certainly,
Do you inject to
I
all
think
the patients?
yeah. Okay. Certainly, all the tension should stay in the muscle level, not in the skin level, and this is also an important point.
Okay.
The second question is that I found that you still use closed rhinoplasty in the primary nose repair, and maybe even in the secondary nose repair. And we now routinely use Tajima reverse U in the primary, as well as a reverse U in the secondary. And we found that it is quite helpful, especially the nasal tip definition. And I saw some of your patients, the nasal tip still you can observe that the lower lateral cartilage is separated in the tip area.
True,
And
true.
so maybe I would recommend that you use the Tajima type of repair in the primary rhinoplasty.
Yeah, after your visit, I'm slowly shifting towards that. So that I'm slowly increasing my percentage of reverse Tajima incision or nostril rim incision for the patients.
Mhm.
I think I'll be able to show better results later when I this thing, 1 or 2 years from now.
Yeah. Thank you. I also like your protocol. Your protocol is quite similar to our protocol. And even your PowerPoint slide style is the same. So
Okay,
really enjoy your presentation. Thank you very
right.
much.
Thank you, sir.
Thank you so much, Professor Low. Next, I will head over and start our Q&A session. So the first question is actually from Dr. Pekorn of Cambodia, And the question for Dr. Bharathi is, how long do patients use the nasal conformers post-surgery in your practice?
So we advise them to use it for at least 6 months, but most of the time they lose it, or if they can, we just make this modified one and give it to them. They can use it as long as they like. Usually 3 to 6 months at least I want them to use it, because by the time the child is growing, at least it's better to go for a better conformer if they can afford it, if it's available. The longer they use it, it's okay. But with Dr. Lowe telling us that just going with the open rhinoplasty may not be much required.
Do you usually follow up the patients and then tell them when to stop, or do you just ask them to stop after 3 to 6 months?
We tell them as long as possible, you try to use it. But most of the time, I find that the complaints rate is not very much. They say the child is not accepting it or this thing. So they have to sort of convince themselves. Otherwise, they blame it on the child and discontinue after about 2 to 3 months, maybe, or even less.
Okay, and our next question is from Dr. Honda from Japan. And the question is, if you set back the protruded premaxilla surgically, how do you do the fixation so that you can prevent injury to the tooth bud?
Okay. In the case which I showed that girl, I just used a single axial K wire, just went in through the single axial K wire from the premaxilla, just went in. Probably, sorry that I forgot to put that X-ray.
Okay, thank you. And our next question is from Dr. Miranthi. And the question is, what are the considerations for mandibular distraction in Pierre-Robin syndrome? And would you consider waiting until catch-up period?
So these distractions have been performed in small kids who had failure to thrive because they were not able to be managed with a conventional treatment like the positioning or the tongue lip additions, which were the thing. So in those cases, we're done. And we have waited for the children to, after that, I showed you the adult picture also, wherein the chin still hasn't caught up, but we'll still wait till the child completes her growth. After that, only we'll try to do something. For the babies, we only thing is the failure to thrive is one of this thing. We can see that retraction of the suprasternal notch and the intercostal spaces due to the obstruction, and the child is really laboring very hard to breathe, allowing it not to grow. In those cases, it's this helps the child very much. Within about 2 weeks, the child is far better.
Okay, thank you. And actually, I have a question for you myself. You
Yeah.
mentioned in your talk about having a dietitian, right? So what
Yes.
role does the dietitian plays in your team?
Yeah, the nutritionist, all the children are screened by the nutritionist on arrival. And even if they present at 1 month or 2 months, and she just measures their weight and length, and we just compare with the WHO growth chart also, whether the child is progressing according to the normal level or either it's in the -1 standard deviation or -2 standard deviation. So in these cases, the child is progressing well. We just follow them up so that we are very sure that the child is growing normally. In case they are in the lesser standard deviation, we just give them the nutritional advice as to how the child has to be fed and what all to be fed. And in case it's still lower, we were able to give the nutritional supplements also in case it's necessary, so that the child can be helped to gain weight so that the child is ready for surgery in that time.
Okay, thank you. And one last question. Is there
Yeah.
any advice for all the doctors out there who might be trying to start up their own craniofacial center or trying to start their own journey in the cleft care? Is there any advice that you'd like to give them?
I think initially when you go, you're going alone. As and when the other team members arrive, I think you should be good enough to welcome them and retain them and get your own learning so that this thing. So as a team, you can perform better. Always they say together each achieves more. TEAM, team. Together each achieves more. So that's the way you should say. By myself, I couldn't have given all these good results to the patients, on the maxillofacial surgeon, the speech therapist, and everybody plays a good role, orthodontist, like that.
Okay, thank you once again, Dr. Bharathi, for your great presentation.
Thank
And
you.
I'll hand the
I
podium back to
I,
you.
I
Yeah,
have some
Professor Low
question
has questions. Yes,
for Dr. Abi. Abi, you
yes,
mentioned,
please.
can you talk about the crab care in India? I mean, do you have some kind of national insurance for all the crab related treatment, surgery, orthodontist, speech, or nutrition, or is completely rely on the smart trend support?
Yeah, smile train support only, because very less percentage, very almost a minuscule percentage only go for the insurance. I don't think so far we are treated. So all these kids get a nutrition supplement and other things from the smile train funding, the speech therapy, everything, orthodontics, the smile train takes care of a lot of stuff. The hospital subsidizes a lot, and with the available grants from the smile train, we are able to give the good treatment to them.
Yeah, very nice dedication. I mean, I would like to thank you for the
Thank
crab care
you.
in India. Thank you very
Thank you.
much.
Thank you, sir. Thank you very much for the opportunity.
Yeah, thank you, Professor Low. And by the way, I have one question for Professor RB.
Yeah.
We probably lost one of the slide of how you to evaluate the VPI when the children are entering to the primary school. So could you maybe to try explain once again to how to evaluate VPI in your center? Thank you.
The children's was quite cooperative enough. We just use a rigid endoscope, nasally and orally also. I just have a 30-degree scope which I pass through orally, so that it doesn't give much of discomfort to the child. And I look from below, from the oral cavity, how the velopharyngeal closure occurs. The child is cooperative. I can go for with a 0-degree scope in the nasal side also, and I see that this thing. In case the child is not cooperative, we wheel them into the theater, and there the cath lab is there. We do a video fluoroscopy on them to assess the velopharyngeal insufficiency.
Sure. Okay, thank you. And what is the surgery you will provide to treat the VPI in your center? Yeah, thank you.
Most of the time, I think majority of the patients will get a furloughs with a suspension pharyngoplasty. It's not a very big one, very big, wide pharyngeal flap. It's a furloughs to lengthen it, and a narrow pharyngeal flap which will suspend it. So most of the time it is the patient.
Okay, yes. Thank you, Professor Abi. Yeah,
Thank you.
and I would like to maybe to invite all our participants. Maybe it's time for our group photo time, because I saw lots of the very similar and familiar names when you guys were in Taiwan to come here for the Chang Forum. For example, Anna, you are here, and you can open the screen to show yourself with us, and probably maybe the Misra and the Sanyo, yeah. And it's time for us to have a group photo. And definitely, thank you. And Anna, hello from Colombia. Nice to see you. Long trip from Colombia to Taiwan. Thank you for your coming. Yes.
Thank you. Hello. Hello.
Hello, Anna. Yeah, and Purdue. It's nice to see you, Purdue. Hi. And yeah, and EI. Nice to see you from Myanmar. Okay, so
Hello, everyone.
Our Professor Low, do you have any warm regard to all our participants here? Yes.
I would like to thank Dr. Zhou to organize this ICC, and every one of us share opinion, and also this time Dr. Abi present his experience. I really admire Dr. Abi, his job in India, and I visited Coimbatore some time ago. Doing really good job, very nice surgeon. Operation very fast.
Thank you, sir.
Okay.
It's very fast. Yes, actually, we have one member here is the student of Professor Low and Professor Avi as well, and she is Nisha. But I have to say congratulations to Nisha to have the first baby, probably 2 weeks ago. But probably she is very shy, cannot show her face now. So congratulations. So by the way, it's time to hope you guys can have proof photo with us. And please prepare your beautiful smile. Thank you. And thank you, Dr. Sosa. Thank you very much. I will count to 3, and probably you can give me a heart on your face or like this, anything. It's okay. And thank you, the Pencon. So 1, 2, cheese. Thank you very much. Yeah, nice to see you here. And I have to advertise our next ICC webinar. The date is in December 10th, and we invited Dr. John to give us a kind of a facial contouring surgery from Korea. And Dr. John is the graduate from Asa Medical University, and his expertise is do some rhinoplasty, facial contouring, and aesthetic surgery as well. And we will give the you guys all very familiar, so we can see the advertisement in Facebook. And we will update our new program in the following 1 year, 2024 too. So thank you very much. Good morning and good evening, and good luck, Professor Low's mission in Philippines since now on. Okay, good luck. See you. Have a good night. Have a good day. Bye-bye.
Thank you.
Bye-bye.
See you.
See you. Thank you, Professor Abi.
Thank you.
Thank you
Bye.
very much. Bye-bye.
Thank you so much.
Yes. Thank you, Bolton, and thank you, EK. Thank you. You both are very good panelists today with a very nice discussion with Professor Abi too. Have
Thank
a
you
good
so
night.
much. Thank you.
Yeah. Bye-bye.
Ya, meşhur zorat. Me anjı.